Welcome everyone to our normally on Thursday, but today it's a Tuesday webinar. We're glad to have you with us. My name is Lourdes. I, as always, would like to remind you to please put any questions that you might have into the chat or the Q&A, and to please make sure you put your questions in a general nature, so not specific to your case, as our speakers cannot answer your specific questions. I am happy to introduce Dr. Lipika Goyal. She is an associate professor of medicine at Stanford University and the director of gastrointestinal oncology at the Stanford Cancer Institute Center. She holds her MD from Harvard Medical School, and her current work focuses on developing novel therapies in clinical trials for patients with gastrointestinal cancers. Thank you for being here.
Thank you very much, Lourdes, and thank you all for attending today. You know, it's really an exciting time in drug development for cholangiocarcinoma because there's lots of new FDA approvals over the last 5 years in this disease. And so we have the distinct honor of having 2 patients who have benefited from some of the new drugs that have been FDA approved. We have Fred and we have Amber, who have very graciously agreed to dedicate their time to help us all learn from their experience about their experience on the FGFR inhibitors. I know you're all here to hear about how we can do better with these drugs and have quality of life be better on FGFR inhibitors. So how we manage the side effects of these drugs. Who better to hear it from than 2 patients who have gone through some of these side effects and have managed them very well. So I thought we could kick off with Fred, who's kindly joining us here from the hospital, and he's going to share a little bit about his experience. And then I will give a little bit of background on where we are in general with cholangiocarcinoma drugs right now, then focus on the new FGFR inhibitors that are FDA approved and also in clinical trials right now. And then the rest of the time, I'll focus on talking about some of the side effects and how we manage those side effects. And we'll have Amber jump in with her story as well. Okay, Fred, take it away.
Thank you, Dr. Goyle. Yeah, I'm live from MD Anderson after having a liver biopsy, and glad to be here. Lourdes, if you would, if you can call up my PowerPoint, I'll keep this short and sweet, hopefully. Just to give you an idea on my journey, I was diagnosed in October of 2019. I'm celebrating my 6th year of treatment, and the first 11 months I was on gem-cis chemotherapy. This is pre-immunotherapy on top of it. My platelets got too low consistently to the point where I had to get off of it. I have intrahepatic cholangiocarcinoma, and one of the concerns at MD Anderson with Dr. Javale was my largest tumor was 18 by 7 by 8 centimeters, which is basically 4 sticks of butter. And it was encroaching upon my main bile duct along with hepatic vein, and I had immediately SBRT radiation on that large tumor. After I completed that, I'm fortunate to have the FGFR2 fusion mutation. And several months prior to that, FDA approved pemigatinib is the first FGFR2 targeted therapy treatment. I went on it for 2 years, and it kept things stable, as did the original chemo. Didn't have any tumor size reduction at all, but quality of life was maintained very well. Once it stopped working, I immediately went to futibatinib, which was fortunately released a couple months before pemigatinib wore off. And I was on that for 2.5 years, and I had significant tumor reduction up to 45%. So I had my large tumor eradicated by the SBRT. I had 3 large golf ball sized tumors in my liver, which shrunk to the size of 3 centimeters. All 3 of those were destroyed by microwave ablation. I've since had another microwave ablation on a tumor. And then I've had 5 days of proton beam therapy and 5 days of SBRT on a pelvic bone tumor. And my platelets got to the point where they weren't recovering. So this year I've actually had two arterial splenic embolizations, which basically they stop flow to a portion of the spleen. And the spleen's just basically a big bladder that holds your red, white blood cells and platelets. So rather than going into the spleen and hiding out, it keeps the embolization allows the platelets to stay in my bloodstream. And that has been successful. I did 2 months of gem durvalumab, and I did run into platelet situations again just with that combination. So I opted to go into a clinical trial, which is DS 3939A, which is an antibody drug conjugate. It's a kind of a two pony drug. It's got a carrier drug that seeks out the MUC1 protein on the surface of a cancer cell. And it's kind of the DoorDash driver for delivery of the chemo to the site. And I've had 2 infusions of that and just got, I just received my scans yesterday, and it looks like things are stable. So uh, what I'm going to talk to you now is about basically the major side effects with FGFR2 targeted drugs. And I had these side effects both with the Pemazir, pemigatinib, and futibatinib, which is also a brand name Leqobi. One thing I was concerned about was vision. The longer you're on these drugs, you can have the possibility of getting some fluid buildup behind your retina, which did occur to me. The good thing about it is I go to an ophthalmologist every 2 months when I was on this, and got an OTC scan, which think of as a CAT scan for your retina. And if they saw fluid buildup and my vision went bad, I'd get off the drug for anywhere from 5 to 10 days, and it's self-corrected. So it's not permanent, but something you need to be very, cognizant of. Probably the most debilitating to me is the hand-foot syndrome, which was progressive. Hand-foot syndrome, you tend to lose your fingernails, they defoliate, recede, get inflamed. Your hands get inflamed. Uh, I lost my fingerprint, so picking up a glass of water is very difficult because it would slide right through my hands. Then I also got some rather large calluses on my fingers and on my foot, which really hurt to the point where it's very difficult to walk. Uh, Other side effects are dry eyes and dry mouth, fatigue, uh, like chemo and radiation, all the drugs we seem to take, and other external treatments cause fatigue. And one thing I noticed, and I know a lot of patients who on the FGFR drugs, is lower back pain, leg pain. So Lourdes, go to the next slide. Now, the center shot is kind of a large corn lesion that develops. You can see my foot's pretty red on the bottom, very tender, but that corn that developed just about kept me from walking. It was so painful. The 2 finger shots, it's hard to see, but if you look on the edges of my tips of my finger, you can see large calluses. This is present day. I've been off futibatinib now for almost 7 months, and my hands are better, my feet are better, but those little corns, for whatever reason, won't go away, and hopefully in time they will. So the hand-foot syndrome, you get also nail defoliation. This is, again, is me now in the last week. It's hard to see, but your fingernails tend to flake, split, recede, separate, as well as your toenails. And that large, ugly toenail, I apologize for ugly feet. Uh, it during the time I was on Pemazir and futibatinib, that would be swollen about 3 times as thick as what you're seeing there. And you need to be aware of proper care for your hands and feet so you can function. If you go to the next slide, Lourdes. Now, I'm really proactive on over-the-counter drugs and medication and prescription medicines. I contacted my dentist right away because I knew that mouth sores, dry mouth was going to be a possible side effect. So the dry mouth I handled with my dentist gave me a prescription of chlorine dioxide solution. Those 2 large bottles, you basically squirt a couple mils of part 1, part 2, swirl it, and it generates chlorine dioxide, which keeps bacterial counts under control in your mouth. Chemo and some of these drugs also impact your enamel, and the little tube you see there is very high concentrated fluoride toothpaste, which is prescription. And then lastly, for dry mouth, which is probably the biggest problem, particularly at sleep at night, where I'd wake up with my tongue stuck to the top of my mouth because your mouth gets so dry, is Xylamelts, and you basically, it's like a large aspirin that you wet and it sticks to your tooth or your gum and provides a little bit of saliva all through the night. So your mouth stays wetted and you can sleep without discomfort. For the dry eyes, I relied on Sustain with a high glycol content, which is the eye drops on the left. And then at nighttime, I would get the Sustain gel and coat my eyelids and put a little of the gel in my eye itself, and it kept things lubricated very well. I did this for 4.5 years and really didn't have any significant problems with overall dry eyes or any infections in my mouth, which some people do develop. Next slide.
You were very proactive, Fred.
Yeah. Some of the folks that were already on futibatinib had recommended urea cream for your hands during the daytime, and that works. If the pain got too bad, I had a prescription of lidocaine. It's short-lived, but it's good relief. And for walking, I can't overemphasize getting good quality shoes. Hoka's, On Clouds, the middle one, the purple shoe is what I use. It's called the Surfer Edition. That's the softest, most comfortable walking shoe I found. And I wear those even today. And then if you want to go out, walk around the house, go to the pool or anything like that, I think it's called OOFS, OOFOS. Those sandals are very, very comfortable, and they relieve a lot of the pressure associated with any kind of soreness, along with the corns that I have. And I could walk and function really well. And Dr. Goy, you may know why, but some of the patients mentioned the antihistamines, Claritin, and I started taking that, and it actually does help relieve back pain. Why? I don't know. But rather than taking oxycodone, which I would take maybe once a month if it was really bad back pain at nighttime when I'd lay down, for whatever reason, the antihistamines worked very well with relieving some of the back pain.
Yeah, that's great. We often use antihistamines when people get like the Neupogen or the Neulasta, because that causes like this inflammatory pain, and that really helps. But it's great to hear that's also helped with the FGFR inhibitors. I'm learning in this webinar as well.
Yeah, and I mean, these drugs work very well. They tend to last much longer than the chemos, because chemos eventually wreck your blood, platelet counts and stuff like that. And, I was on them 4.5 years, and there's other folks that are on it longer. And very fortunate the quality of life is able to be maintained, and just be proactive, start early with the over-the-counter stuff for your eyes, your mouth, and be cognizant that you could have some feet issues for just mobility. But that's it in a nutshell for me. It's I can't think enough or speak highly enough about all the new drugs coming out there, particularly for FGFR, that I hope to be on soon.
Thank you, Fred. Thank you for sharing your story. And it sounds like you've been so proactive about managing the side effects to be able to enable you to be on it for 2 years and 2 years and now on the new clinical trial. I think definitely because of side effects, we sometimes have to reduce the doses. So if we can be really proactive about managing the hand-foot syndrome, the toxicity with sometimes people have mouth sores, sometimes people have issues with their eyes. Being very proactive about all that really helps people stay on the highest dose for the maximum period of time. So thank you for sharing your story. So I will first do a quick overview of where we are with cholangiocarcinoma, because I think that there's a lot of hope in the development of FGFR inhibitors and drugs for other targets. I'll also very briefly show you how to read some of the plots you might see when you're looking at all the new research for the clinical trials. Some of you I know like to look at the slides from the different cancer conferences. I'll very briefly go over that just in case that's helpful. And then we'll jump into how to manage the side effects. And then Amber will be our closing act. Okay, so managing the side effects of FGFR inhibitors. Let's see if I can put this in presenter mode. Okay, can you see that? Great. Okay, a few of you have seen me talk before, have seen me do a slide like this. I talk about how back in 2010, when I was in fellowship, this is what the landscape for cholangiocarcinoma looked like. It was like 6 little birds on a wire. There weren't a lot of people studying this disease. There weren't a lot of pharma companies that were interested. There weren't a lot of scientists that were making models in the lab. And fast forward 2025, this is what the landscape looks like. There are a lot more birds flocking to the wire. There are a lot more companies that are interested in this. I remember in 2010 when I went to conferences, I would go with my mentor and we would go to different companies and say, hey, your drug is working in pancreas. Can you please give it to us for a small trial in cholangiocarcinoma? And now when all of us who study cholangio go to conferences, companies are constantly flocking and saying, hey, can we talk to you about our new idea for patients with cholangiocarcinoma? And if clinicaltrials.gov is any indication of how much enthusiasm there is to try to develop new drugs in this disease, you can see that the number of clinical trials that are interventional trials has gone up about 7 to 8-fold over the last several years. So that's all very promising. And then also in 2024, there were about 8 different drugs that are approved for gastrointestinal cancers. This is a picture of the gastrointestinal tract. And biliary tract cancer made it onto that list. There was one drug that was approved in 2024, and it was zanidatamab for HER2-positive cancers. That's very exciting. And if we look at all the FDA approvals that are available for patients with biliary tract cancer, on the right, you'll see the importance of molecular profiling or tumor sequencing or genetic profiling, all different terms for the same idea, which is to take a look at the DNA that's in the cells of the tumor and sequence it to see what kind of spelling mistakes are in that DNA or mutations. And then we have targeted drugs that are able to go after the cells that have that particular type of mutation. And about 40 to 50% of people with intrahepatic cholangiocarcinoma, about 20 to 25% of people with extrahepatic cholangiocarcinoma, and about 20 to 30% of patients with gallbladder cancer have some of these targetable mutations in their tumors. And as Fred said, chemotherapy works, it's helpful in this disease, but over time, it also has side effects like burning out the bone marrow. And so being able to have these alternatives is really great. So definitely, if you haven't already, talk to your oncologist about getting your tumor sequenced. So we had a couple of different therapies that gained approval. FGFR inhibitors were the first drugs to get FDA approval in this disease. It was pemigatinib in 2020. But also, as Fred mentioned, he got GemCis before the immunotherapies were approved. In 2022 and 2023, there were immunotherapies approved in combination with chemo in the first line. And then for people who have tumors with FGFR2 fusions, IDH1 mutations, or HER2 overexpression, we also have a bunch of different drugs. And then those are specifically for people with cholangiocarcinoma or biliary tract cancer, but we also have disease agnostic approvals. What does that mean? That means whatever cancer you have, if your cancer has one of these alterations, there's an FDA approved drug that you can get access to. Because, for example, MSI high, microsatellite instability, that is seen in about 1 to 2% of biliary tract cancers. So it's really hard to run a trial only in patients who have MSI high biliary tract cancer. So they do these big basket studies, and then anyone who has a tumor that's MSI high can get access to immunotherapy. So all in all, there's 6 FDA approvals for biliary tract cancer between 2020 and 2024. And there are many other disease agnostic. So lots of different options. Talk to your doctor about these different options. And to show you sort of what the landscape has been like, for about 10 years right here. Can you see my pointer here? Yeah, great. For about 10 years, all we had was chemo. And then here, starting 2020, we have all these new approvals. So that's really exciting to see that the landscape is getting crowded and we're having a lot of action in the last 5 years. And everything above the line is for biliary tract cancer. Everything below the line is those disease agnostic or tissue agnostic, meaning any cancer that has these mutations. They're different drugs. And I also wanted to explain, I know a lot of people go on clinical trials, the different types of clinical trials we have when we're trying to evaluate targeted therapies in an uncommon cancer. When there's enough promise for a target and some exciting drugs and an initial signal in the preliminary cancers, in the preliminary trials, we actually move to these target-specific trials, which means that everyone in the trial has the same mutations. So, for example, FGFR2 fusions, and they have the same cancer. So these are trials in very specific populations like FGFR2 fusion positive cholangio. Then we have basket trials, and those are when it's a rare mutation. They take all patients with different kinds of cancers that have that particular mutation, and then they see, is there a signal in cholangiocarcinoma? And a lot of these different mutations, they were first in basket trials, and there were a couple of patients with cholangio that had a really remarkable response, and then those companies shifted and did a cholangio-specific trial. And then the last one is these umbrella trials, where this is going on in the UK right now, where there's anyone with cholangiocarcinoma can get enrolled on this trial, and if they have a particular mutation in their tumor, they can go on a targeted therapy. If they don't, they can go on Gemcis, Durva, Gemcis Pembro, for example, or some other backbone. And so these are the different kinds of trials that people can get involved in, and there's a reason and merit for all of them. And again, we're going to go with FGFR2 fusions. So here are the 2 drugs. I'll start with pemigatinib, and on the right side of the screen, I'll show you about futibatinib. Here are the 2 drugs that have gotten FDA approved for FGFR2 fusion positive cholangiocarcinoma, which is seen in about 10% of intrahepatic cholangio. As Fred mentioned, that's the type of cholangiocarcinoma he has. And Amber will also talk about that's the kind of cholangiocarcinoma she has. So pemigatinib, the overall response rate is about 36%. You will see these plots very often when you look at cholangiocarcinoma papers and any cancer papers. These are what are called waterfall plots. Each bar represents one patient. And what you want is you want falling water. You want a lot more bars going downwards because this is the amount of tumor shrinkage. So these people had 100% tumor shrinkage. Anything that's below this line, this is a 30% mark. You will notice that a lot of these trials will report out what is the overall response rate. Overall response rate means what percentage of patients had at least 30% shrinkage of their tumors. And so anyone with a bar that falls below this, that means each of these patients had more than 30% shrinkage of their tumors. So that's 36% of patients with pemigatinib. And just to give you a comparison, with FOLFOX chemotherapy, that ORR, that overall response rate, is 5%. So this was really an earthquake in the field of cholangio that we saw, like a 7 times rate of tumor shrinkage. With futibatinib, this is an irreversible inhibitor. This had a 42% response rate, and you can see the numbers here. You can see a lot of patients also with falling water having tumor shrinkage right here. What happens is these drugs work for a period of time. Fred luckily had the benefit of being on these drugs for 2 and 2.5 years. On average, they work for about 7 to 9 months. And then these tumors that look like this to begin with, when you treat with an FGFR inhibitor or other targeted therapy, it selects for certain tumor cells that are resistant to that drug. And so the black ones are the sensitive cells, the red ones are the resistant cells. And in the beginning, there's either no resistant cells or very few. But as you treat with for 7 months, 9 months, 2 years with these FGFR inhibitors, the cells that are resistant start to grow. So the big thing in cancer care is, can we develop drugs to overcome this resistance? Many of us who study resistance try to understand what is the reason why these red cells are popping up, what's different about them. So we do something called liquid biopsies, and that's basically doing a blood test every couple months to try to understand why is the drug not working as well anymore, so we can understand the emergence of resistance. And we look for these different mutations in FGFR which prevent the drug from binding to the receptor. And so in collaboration with many patients, with many cancer centers, with many oncologists, we were able to gather many different liquid biopsies, tumor biopsies, and autopsies after people passed away. And we were able to try to understand what are the mechanisms of resistance. And this is some of the foundational work that helped lead to the development of the new FGFR inhibitors. And the futibatinib trial, they had the prescience to recognize that we're going to need to understand why futibatinib fails patients after a period of time. So they actually collected blood, and patients generously donated their blood to be able to be analyzed to understand at some point, why do people develop resistance to these inhibitors? And you will see sometimes people develop mutations in this. This is called the gatekeeper mutation. Some people develop mutations here. This is called a molecular brake mutation. And then the next generation of FGFR inhibitors are specifically developed to overcome the specific mutations we see in people's tumors. So this is one drug. We're going to hear more about this drug in 2026. It's a drug that was previously owned by Relay Therapeutics, and now it's owned by Elevar. It used to be called RLY-4008. Now it's called lirafugratinib. This is a next generation FGFR inhibitor, and it specifically targets FGFR2. Why is that important? When Amber talks, she's going to talk a little bit about some of the diarrhea that she's had on one of the drugs that she's been on. Most of the FGFR inhibitors hit FGFR 1 through 4. When you hit 4, you get diarrhea. When you hit 1, you get high phosphorus. So this is a very special drug that only hits FGFR2. But it hits it really hard, and so you also get some of the FGFR inhibitor side effects from it. The benefit of having a drug that hits FGFR2 very hard is that you get a lot of green lights against a lot of these different mutations that develop on the other FGFR inhibitors. So in places where some of the earlier generation FGFR inhibitors fail, potentially this drug can overcome it. And what we did see was that in patients who had no prior FGFR inhibitor with this drug, they found that 60% of patients plus ended up having tumor shrinkage. When you look at people who just got 70 milligrams, that number rose to over 80%. That was in only 15 to 17 patients. So in 2026, we're going to see the data from 100 patients that were treated with this drug who had never had an FGFR inhibitor. So watch this space, because that could be an option that's available potentially for patients in the future. This is another drug, and Amber is going to talk about this because Amber is currently being treated on this drug. It's another next generation next generation inhibitor. And I will just say, before I started this webinar, I talked to Amber before I started, and I said, is there anything off limits? Is there anything I can't say? Because I have the distinct honor of being Amber's doctor. And she very kindly said, if there's anything that I've been through that can help another patient, I'm all for you sharing, Dr. Goyle. So that's all. Thank you very much, Amber, for letting us be able to share your story. So this is the next generation FGFR inhibitor. What's special about this FGFR inhibitor is that the other FGFR inhibitors, they can potentially get blocked by the gatekeeper mutation, which is a mutation that sticks an elbow out in the pocket so that these drugs, which normally bind like this, can't bind. Tinibotinib binds just outside of this, so it's theoretically not inhibited by the gatekeeper mutation, which, as I showed on this slide, is a large percentage of the people that go on these FGFR inhibitors. This red one is the gatekeeper mutation. So this drug potentially has an advantage in that way. And it also creates 3 hydrogen bonds as opposed to 1 to 2 hydrogen bonds with some of the other drugs. So it's particularly supposed to be a very potent drug. And as you can see right here, it potentially is able to have greens where some of the other drugs have reds. So this was tested in a phase 3 trial. Dr. Fred had mentioned Dr. Javle at MD Anderson, which I know everybody knows very well. He was one of the people that led the development of tinnigotinib in cholangiocarcinoma. And many of these patients previously got FGFR inhibitors, and you are still seeing falling water. Again, each bar is a patient. Anytime you hit below 30%, you're getting significant tumor shrinkage. And honestly, even people who have stable disease, who have minor shrinkage, that's also success, because if someone's feeling well and their tumor is under control, that's also great news. And so there are several new drugs. There's a drug by a company called Cogent, a drug by a company called Tyra, and several other drugs that are in clinical trials. So anyone who has any kind of FGFR alteration, certainly be on the lookout for different trials that we have. So now moving on to the toxicities of the FGFR inhibitors, we see people have hair loss, they have mouth sores, they can have some halos that they see when in their vision, and that can be some fluid behind the retina. They can have some high phosphorus. They can have joint pains, diarrhea if you're hitting FGFR4, some elevation of the liver enzymes, and some of the hand-foot syndrome that we talked about. All of those are things that are very manageable in the clinic, but they certainly affect people's quality of life. And so they're worth going over a little bit more. Does anybody have any questions in the chat before I go on to that? I'm just going to take a look real quick.
I think there was just a question for Fred,
Okay.
who was asking how soon after beginning the FGFR inhibitors did the various side effects start, and did they get progressively more pronounced over time? Oh, Fred, you're on mute.
Okay, sorry about that. Good question. Um, Pemazir, it is progressive. The longer you're on it, all the symptoms tend to progress. I can't say that one's worse than the other. And when I went to futibatinib, I had already had symptoms that I had discussed, and I think they just compounded. I don't know if futibatinib caused more significant hand-foot syndrome, or if it did, it's possible, or just the fact that I'd been on both drugs for so long that it is progressive. Yes, for most of these side effects.
Yeah, that's been my experience as well in treating patients, that the longer people are on the FGFR inhibitors, the more nail toxicity they have and the more hand-foot syndrome they have. What's very interesting is that some people have the nail toxicity, some people have the hand-foot syndrome, some people have very bad mouth sores. No one gets everything, but it's very interesting that certain people, they are more tending towards a certain set of side effects. But it's very hard to predict who's going to get which side effects. And I see what Fred is sharing also, that sometimes if you're on one drug for a while and you get hand-foot syndrome, we try to let people get a little bit of a break, let the hands and feet recover. But then when they get on the second inhibitor, sometimes that can get worse. But Amber is going to share a story how she went from one FGFR inhibitor to another, and her hands and feet were actually fine on the second inhibitor. So we'll talk about that.
Dr. Gloria, the other question that came through, just if you
Yes.
can address it. Someone is saying that they often feel strange skin sensation of numbness, and that their torso and face has also felt that sensation of numbness when palpated. I don't know if that's something that other patients maybe have felt while they were on this type of medication?
That's a good question. The one time I had seen this is in a patient whose phosphorus was a little high or whose calcium was a little low. And so the one suggestion I would say, if anyone has any numbness or tingling in their face or anything like that, to consider getting the electrolytes checked, because sometimes it can be an electrolyte issue. But otherwise, it's not a common side effect that I have seen. So these are the most common side effects that we see with the FGFR inhibitors like pemigatinib and futibatinib. I'll just share one slide that I got this morning, fresh off the press. Many people know that ESMO is going on right now. ESMO is the big European Cancer Conference. It's just like ASCO, which is the big American Cancer Conference in Chicago in May, June every year. ESMO is in September, October every year in a great European city. So Dr. Javle just presented this with tiningatinib. Tiningatinib is an FGFR inhibitor, but it also hits another protein called VEGF, vascular endothelial growth factor. And when you hit that specific protein, you end up getting high blood pressure. So about 55% of people on this FGFR inhibitor got high blood pressure that was mild or moderate, and then 26% of patients had more severe high blood pressure. Diarrhea is a common side effect, and Amber has unfortunately had to wrestle with this a little bit on tiningatinib, and she's going to talk about that. Stomatitis means mouth sores. That's common on the FGFR inhibitors. Majority of it's mild, and you can get away with some different mouthwashes that we'll talk about. And I know Fred mentioned some antibacterial mouthwash as well. This is hand-foot syndrome right here. You see it on all these oral pills. The thyroid can go a little up or down on these drugs. Fatigue, nausea, and decreased appetite. And this is how often the drug was interrupted or reduced or stopped. Okay, so let's take each of these. These are like doctor slides, you know, about how we teach other doctors about how to manage this. But I wanted to just like highlight a couple things about how your oncologist looks at these numbers and how they make suggestions for you about what to do next. So I will tell you, when we first started giving these drugs in the clinic, my entire research team and myself, we all went on a low phosphorus diet just to understand better what patients are going through. And we asked them to be on a low phosphorus diet. It is hard to be on a low phosphorus diet because one, anything brown, like brown rice, brown pasta, brown bread, all has a lot of phosphorus. A lot of nuts have phosphorus. Red meat has a lot of phosphorus. Coca-Cola has phosphorus. Anything with dairy, like milk, cheese, ice cream, which I love, butter, you know, all this stuff has phosphorus. So it's not easy to cut phosphorus completely out of your diet. We don't recommend people do that because, you know, food is the joy of life. But, you know, being mindful of your phosphorus intake is one way to make sure that you don't have high phosphorus. And then we do have these different drugs that you can take just before you eat a meal, because what they do is they bind the phosphorus in your food. The one issue with phosphorus binders is they can cause constipation. So the way you eliminate phosphorus from your body is just by peeing it out or pooping it out. So staying really well hydrated and taking laxatives as needed to prevent constipation are also ways to help prevent having high phosphorus. We used to be much more aggressive about stopping FGFR inhibitors when the phosphorus was high, but in the vast majority of patients, the high phosphorus doesn't cause any issues. Every once in a while, if the phosphorus and the calcium are high, people can get kidney stones, or they can get little calcium deposits in their muscles that can actually be painful. It's extremely rare, and for the most part, the high phosphorus is just a lab abnormality. The hand-foot syndrome, I think we heard from the experts. Fred talked a lot about what he did. Amber's going to talk about what she did. Basically being very proactive and mindful, because this is one of the reasons we have to hold drug or go down on the drug. Being very proactive helps people stay on the highest dose of the drug for the longest period with minimal dose reductions. So the urea 20 to 40% is what I prescribe almost all my patients just when I see a hint of redness. It happens also because of friction. So as Fred was saying, be mindful of wearing very comfortable, non-tight shoes, because, you know, people love to walk, and that friction can sometimes worsen hand-foot syndrome on the feet. If the urea cream is not enough, I usually recommend that people put steroid cream on their hands and feet twice a day. Let that absorb for some number of minutes until it's absorbed, and then add the urea on top of that. That tends to help people. We very quickly refer patients to dermatology, and Amber is going to talk about the wonderful dermatologist that helped her with her diagnosis, because sometimes it's not only hand-foot syndrome alone, it could be something else going on. So really important to partner early with our dermatologists. Stomatitis or mouth sores is another common side effect. Again, food is a joy of life, and so it's really important that we all are quite aggressive about making sure we manage mouth sores. First step is the usual that we recommend on chemo, which is baking soda mouthwashes or saltwater mouthwashes a couple times a day. My patients who do this 3 or 4 times a day are often the ones that do the best with this. I know it's not easy to do it 3 or 4 times a day, but that's usually my step 1. Step 2 is I use this steroid elixir, dexamethasone elixir. And then I know Fred mentioned some antibacterial mouthwashes that you can use, because when people have dry mouth, you can't fight off the bacteria as well. And then there's some other, magic mouthwash if people have pain. I think Fred was mentioning some lidocaine that he also used for stomatitis. Some people get it on their lips, and we can give like lidocaine for the lips as well. So again, we work sometimes with dermatology even has some suggestions here. Paronychia is a nail infection that happens in the bed of the nails. It's important to get on top of this early, because a quick course of antibiotics can usually nip it in the bud. If you notice that there's any pus coming out from your nail beds, that's something that is probably caused by the FGFR inhibitor. Usually we can do something topical, such as a little bit of clindamycin, which is an antibiotic. And you can also do soaks in white vinegar and water. But if that's not enough and you're really seeing pus, then we recommend antibiotics. Very often we'll send people to dermatology. I've also used drugs like Celebrex, which is an anti-inflammatory, and that has also helped several people who have this side effect. Dry eye, Fred mentioned a little bit about the artificial tears. He talked about cystine, these thick gel-like substances, which people can put in their eyes or on their eyes, can be really helpful. Different FGFR inhibitors recommend different frequencies of eye exams. That baseline eye exam is really important, so that one, we make sure the FGFR inhibitor is safe for you. And then also, just so you have a relationship with an eye doctor. So if you notice that you're having floaters, halos, one of my patients was seeing hearts around everything in his vision. All that stuff could be a sign that you're having a little bit of retinal detachment, which sounds scary, but for almost all of my patients that have had it in the past, you stop the drug, you restart it 3 to 4 days later, and it never comes back again. For some people, when you restart, it comes back again, and then I drop a dose. But we work very closely with our eye doctors to make sure that we are managing any eye side effects. But the baseline eye exam is really important. And then this is for the hand-foot syndrome. And then if people have hair loss, which can sometimes happen with this class of drugs, people can use some minoxidil or Rogaine. This is a common one, and I don't know if Fred or Amber, you want to talk about the nail issues from this a little bit. I know, Fred, you were mentioning it a little bit, and your nails, it sounds like they were growing back a little bit once you stopped the drug. But people sometimes have their nails separate from their nail bed. They have nail loss. So just clipping your nails so they don't get caught on things, and putting a little bit of clindamycin under and around the nails can be very helpful. What I have found generally for a lot of these toxicities, go ahead, Amber.
So yeah, I had that when I was on futibatinib, and you'll be able to see that in some of the pictures that will be shown of my hands.
Okay, thanks for sharing. What I definitely have heard from my patients is that the chat rooms have been really helpful for people to get good advice on different kinds of drugs to use for people for different side effects. So I encourage people to continue with this community. The other thing that happens is sometimes people can get very long eyelashes, which can be great in some instances because they're beautiful, but in other instances, those eyelashes can actually grow underneath your eyelid and can scratch your eyeball, and that's not fun. And so I've had some instances where people have had to get epilation, which means that they have to get their eyelashes removed. Not very common. I've probably seen 2 patients in my whole career who've needed it, but if your eyelashes get too long, there are a couple of different things that you can do. And that's what I got for side effects. That was a whole tour de France of lots of different side effects of FGFR inhibitors. I just wanted to make sure that I was thorough. I see that there are a bunch of questions in the chat. We can answer a couple of those quickly, and then we'll hand it over to Amber for the last 10, 12 minutes.
Dr. Loyal, can you address maybe about the hypophosphatemia that is not resolved with infusions? Any suggestions on that?
Hypo, like HYPO.
Yes.
So sometimes with some of these drugs that you're 3 weeks on, 1 week off, or 2 weeks on, 1 week off, like pemigatinib is 2 weeks on, 1 week off. Number one, it's really important to stop your sevelamer and all your phosphorus lowering drugs on your week off. Sometimes we as doctors and other clinicians, we forget to tell patients that's really important, but you don't want to be dropping your phosphorus when you're not on the FGFR inhibitor. So what we find is sometimes after that week off, when people come in for starting their next cycle, their phosphorus is quite low. That usually just goes back up when they go on the pemigatinib or the futibatinib. Sometimes from withdrawal of the FGFR inhibitor, people have some chronically low phosphorus. That can just be improved with supplements. We normally give people phosphorus packets. That can be improved dietary wise, so people can, just take more phosphorus in their diet. Again, all the dairy and brown bread, pasta, all that kind of stuff. If you just look on the internet, high phosphorus foods, it'll come up. Rarely people have very severe hypophosphatemia where they need to get IV infusions of phosphorus. That's not so common, and it's worth having like a evaluation from a kidney doctor if that happens.
Okay. And then is it wiser to try and start with one FGFR specifically and then move to others sequentially? This person has heard that certain drugs exempt you from trials or other FGFR2 inhibitors.
That's a great question. So I will just go back real quick to the tinningotinib study that's going on right now. So there's a big phase 3 study right now going on with this drug. And for this trial, you can only have had one prior FGFR inhibitor, and it had to be one of the FDA approved ones. So either pemigatinib or futibatinib. Because specifically that's the indication that this drug is going for. It's anyone who's had either Futi or Pemi can then go on to tinningotinib. And so, yes, it's definitely worth, as you're making decisions, to talk to your oncologist to hear what the requirements are to go on to these trials. I think for Cogent, you're allowed either 2 or 3 prior FGFR inhibitors. For Tyra, you have to have one of these different mutations in your blood or in your tissue to qualify for this trial. So each of these have slightly different requirements. And sometimes, I work across the street from Katie Kelly at UCSF, and we have Cogent at Stanford, and she has Tyra at UCSF. So as we take care of our patients, we always say, okay, if we put someone on our trial, it's going to disqualify them for your trial. And what sequence should we put people on trials? So I think it's always worth talking to different people who have these trials and think about, are you closing any doors by going on one versus the other?
Okay, perfect. And then someone is curious to know how many patients you have treated with FGFR inhibitors.
Oh, over 100. Okay, we'll turn it over to Amber.
Well, thank you. Actually, my name is Amber. At this point, I'm basically lurking in the Facebook group, so I've been around. I said I'm around. But as far as my history, I was diagnosed in July of 2023 with stage 4 intrahepatic cholangiocarcinoma. The day I was diagnosed, my oncologist up here, so I'm from Seattle, but I travel down to the Bay Area to see Dr. Goyal. My oncologist up here at home said that what he wanted to do was to do biomarker testing as well as germline testing. And so we did all of that. And while we were waiting for results, we started on chemo, and I started with the first line of gemcitabine, cisplatin, and durvalumab. And while that slowed the progression, it didn't stop anything. But in the time that I was going through chemotherapy, we got the results of my testing back. And it showed that germline was good. It was negative for any potential mutations or issues that would predispose me to cancer. But when we looked at the biomarker testing, it came back with the big red flag of you have FGFR mutation. I am FGFR RAF1 rearrangement. And that was great in that that opened up a bunch of doors for future treatment. And after my first scan that showed the first line wasn't really doing anything, we immediately moved right on to futibatinib. And Lytgobi is the brand name. And I was on futibatinib from, see, it was about October of 2023 until around April, I think it was around late April, early May of 2024. So about 6 months. In that time, I was definitely, would be in that partial response category. I was just over 30% reduction in tumor burden there. So I had a fantastic response on the futibatinib. And then I was referred down to Dr. Goyal by my oncologist up here for the tinangotinib trial. And I've been on tinangotinib since June of 2024. And I've had a fantastic response on the tinangotinib. But along with that, both on the futibatinib and the tinangotinib in particular, I have gotten some pretty good side effects. On the futibatinib, I dealt with dry eyes, dry nose, dry mouth. It was supposed to be moist. It was not moist. I did end up with mouth sores. The last few weeks I was on it, I did deal with some joint pain, particularly in my hips. I did have hair thinning. I didn't have complete hair loss, but it really thinned out. I ended up with severe hand-foot syndrome on both my hands and my feet. And on my hands, because of how heavily I had to moisturize and even keep things covered because of just the severe hand-foot syndrome, I also developed a fungal infection. And so I'm going to warn you, when you see pictures of my hands, they're going to look pretty nasty. A lot of that nastiness is going to be from the fungal infection, which has completely cleared up. I did end up with hyperphosphatemia on that, and such. So I've had a wide variety of yeah, there's my hands. That was right after, that was right about the time that I stopped the futibatinib. And I worked with a fantastic dermatologist up here who was able to help me figure out what was going on. And I was given a prescription cream to help with the fungal infection, and that cleaned up really quick. On the tinangotinib, I have had hypertension. Very little of the side effects I had on the futibatinib also happened on the tinangotinib. I've had hypertension. I have had hand-foot syndrome, but it's really only been bad on my feet. On my hands, you can't even tell. I've had some mild discoloration of my toenails, particularly early in my treatment. It has done nothing other than just mild discoloration. I have had the dry eyes, mouth, nose, etc. On the tinangotinib, it really gets bad during the night, but I don't even really notice it that much during the day. It's really only at night. The one and probably the worst side effect I've had on the tinangotinib has been colitis, and that has been my constant companion, and probably the worst of the side effects I've experienced on the tinangotinib. I do end up with some decreased appetite, particularly when the colitis flares up. And the nature of the inhibitors, I do get some changes in my sense of taste. Things just taste a bit weird and off, but I've learned the various spices and herbs that don't play well with my tongue and my mouth, when that's the case, and which ones I still enjoy and will happily enjoy. So I've had a wide range of side effects. When we get into the pictures, as shown, my hands, they looked pretty nasty with the fungal infection in the hand foot. I did also have my nails separate from my nail bed. So if you look at the pictures of my hands, particularly when you're looking at the backs, if you want to forward back to that, and up on the nails, you'll be able to see that my fingernails completely separated from the nail beds. I lost all my toenails. Since then, everything has resolved. My hands look fantastic today. You can't even tell. I have nails, they're strong, they're great. These pictures are from actually from my time on tinagotinib, and I do get some pretty good hand-foot syndrome, and I've had some pretty good hand-foot syndrome on my feet. Like with Fred, I've got really good supportive shoes. The dermatologist I had been seeing when I started on the tinagotinib said, make sure you get good supportive shoes, like running shoes, that are wide width to give your feet room, and that's what you'll want to wear. And that's pretty much exclusively what I wear when I go out. When I'm at home, I've got some really good cushy slippers that I wear, that are very similar to that provide some cushioning, and such. The other thing I've done with hand-foot syndrome is I will only wear wool and highly wool blend socks, especially like hiking socks. And the reason for that is wool doesn't compact down like a lot of the cotton and synthetic fibers do. It also breathes easier. So that helps to prevent some of that issue with too much moisture. I've also made sure to moisturize. I do use urea cream, especially if I'm getting some calloused areas. But if things aren't too calloused, then to help with keeping things moisturized, I use, my favorite is Eucerin, I think is Advanced Therapy, but it's Eucerin. The dermatologist I saw said there's a variety of different lotions and creams that they recommended for patients with hand-foot syndrome that just helps to keep things moisturized, that helps keep that moisture in, and it helps just keep things more comfortable. With things like the dry eyes, dry mouth, dry nose, I use re-wetting drops, and usually the gel type as well. I think mine were like a TheraTears or something like that, but it is a really good re-wetting drop. And then there's kind of ointments you can use too at night that help to provide that lubrication and hold some of that moisture into your eyes that I've been able to get over the counter. With the colitis, that's one of those where I've had to, I've actually been dose reduced. I started at 8 milligrams on tinagotinib, and because of side effects, we dose reduced down to 6. And after a while on the 6, we did a final dose reduction down to the 5 milligrams, which is the lowest dose. And even at the 5 milligrams, I can usually go between 3 and 4 weeks before I need to have it held for about a week for the colitis to resolve and my body to decide to behave correctly and to feel better, and then I'm able to resume the tinagotinib.
Amber, I just want to interrupt you very briefly.
Yeah.
You have been so incredibly meticulous about managing all your side effects. And I just want to highlight that because Amber was working so closely with a dermatologist, they recognized that potentially the steroids or other creams that were on her hands that were keeping them so moist led to that fungal infection. As soon as she got the fungal infection treated, everything got a lot better. And so some of these pictures might have been a little scary as to some of the side effects on these drugs. One, both Amber and Fred were on these drugs for a long time, 1 to 2 years. Of course, we wish that was like 10 years, but in the cholangiocarcinoma world, being on a drug for 2 years, these side effects are cumulative. I want to give the microphone back to you, Amber, to keep on sharing your wisdom about tinnigotinib and all your side effects. I unfortunately have to jump to a meeting, but I just wanted to say thank you to the Cholangiocarcinoma Foundation and to all of you who joined today. Happy to help if I can help any of your oncologists with side effects or anything like that. I hope you all get benefit from these drugs, and I hope you're all able to get onto some of these new clinical trials of new promising FGFR inhibitors. Okay.
Thank you. So I've had a gamut of side effects. I've with the colitis, I take a break and I've been able to resume. For the looking at notes as well, to make sure I get everything, because I've had to manage quite a few side effects. For hyperphosphatemia, because I did have that on the futibatinib, I was on a very restrictive diet on top of using the sevelamer carbonate to help bind up the phosphates in my food. And that was difficult because I love my dairy, I love my whole grains and lentils and all that stuff, but I survived and I made it work. For the thinking, I think that covers the really, really big stuff. I see that someone asked, has anyone experienced like crying spells from tinnigotinib? I haven't from the tinnigotinib itself, but I have definitely had enough mental health struggles and such, and I definitely have had tears flow because of that, but not directly from the tinnigotinib.
Perfect. Thank you, Amber.
Yeah.
Trying to see if there's anything that was directly related to side effects. And I think you responded to the one about crying, so that's perfect. I don't see any other questions, and I know that we are at time. I want to just express my great appreciation to you both, Amber and Fred, for sharing your personal experience on these different medications. There is a question that came in. Do you alternate between colitis and constipation?
Early on, I did especially when I was on the 8 milligram and to some degree on the 6 milligram. Less so on the 6. Now on the 5, it's pretty much no constipation. It's no constipation, everything's fine, or colitis. When I was on the 8 milligram and to a lesser extent on the 6, it would be either colitis and it'd be ticked off in that way, or I'd get constipation and things would be unhappy the other way, in that way. So that was a huge challenge because I was going between, do I need something to handle the diarrhea as colitis was starting to set in, or did I need stuff to help deal with the constipation and laxatives to keep things moving through me? And that was a very at times difficult juggling act.
Thank you. I don't see any other questions. Thank you again to you both for taking time to do this and share your experiences. We truly appreciate it. And of course to Dr. Goyle, who was on the call and shared that information. This is recorded, so anyone who is watching this webinar will be up on the CCF YouTube channel for future reference. The link will go out. So thank you to everyone who was on the call and listening in. I hope everyone has a great day.